Hi everyone, my name is Joyce. I'm going to be conducting a comprehensive assessment and we'll begin with assessing your cranial nerves. Cranial nerve 1 is your olfactory nerve. It mediates your sense of smell and it is a sensory nerve. So to begin assessing this, I just want to make sure that your nostrils are patent. So if you could cover your right nostril and breathe in through your left, in and out, and the other nostril, breathe through your right, in and out. Okay, so I'm going to have you identify 2 different scents, one with each of your nostrils. If I could have you close your eyes, occlude your right nostril, and tell me what you think this scent is.
Peppermint.
Okay, and occlude the other nostril, and tell me what you think this one is.
Citrus.
Okay, and you can open your eyes. Patient is able to identify 2 distinct scents. Peppermint and citrus. Cranial nerve 1 is intact. Okay, now we have cranial nerve 2, and this is the optic nerve. It is a sensory nerve that mediates your sense of vision. And to begin this, we'll be assessing your central vision. So I first have to ask, do you use any glasses or contacts to aid with your vision?
No.
Okay, so to assess your central vision, we'll be using a Snellen chart, and I'm just going to have you hold it about a foot away from you. We're going to cover one eye, and then you're going to tell me the smallest line you can read. So first we'll begin with covering your left eye. Okay, and read the smallest line you can read.
LTFPH.
Okay, and now switch eyes. And smallest line you can read.
LTFPH.
Okay. Patient's central vision is 20/20 in both the right and left eyes without correction. Now we'll be assessing your peripheral vision using the confrontation visual fields test. So I'm going to have you cover your right eye first. I'm going to be holding up numbers with my fingers and you're going to tell me what you think they are. But only focus on my nose. Don't move your eye anywhere else.
2, 4, 3, 2.
Okay, and now cover your other eye.
2, 5, 3, 4.
Okay. Visual field is full in both eyes, no visual defects. So now we're going to be conducting a fundoscopic exam using the ophthalmoscope. I'm going to be getting pretty close to your eyes with this light, so just try to bear with me if it gets a little uncomfortable. I'm going to have you focus on one point on the wall, and we're going to begin with your right eye. I see the red reflex is intact. Disc appears creamy white, margins are distinct. Retina is orange, veins are larger than the arteries. Okay, and then the left eye, red reflex is intact. Disc appears creamy white and round, margins are distinct. Retina is orange, veins appear larger than the arteries. Okay, so for both of his eyes, the red reflexes were intact. The discs were creamy white, margins are distinct. There was no swelling and no increased cupping. The retina is orange. There's no sign of hemorrhage on the retinas, no loose spots, and the veins are larger than the arteries in about a 2-to-1 ratio, and there's no increased tortuosity. Cranial nerve 2 is intact. Now we're going to be assessing cranial nerves 3, 4, and 6, and they are all motor. They mediate muscular movement of the eyes, and we check them in combination of one another. Cranial nerve 4 is trochlear. It mediates inferior medial eye movement of the superior oblique muscle. Cranial nerve 6 is abducens, and it mediates lateral eye movement of the lateral rectus. And cranial nerve 3 is oculomotor, and it mediates all other eye movements. First, we're going to check for a pupillary reflex. So I'm going to shine a direct light stimulus into the patient's left eye, and we're checking for pupillary constriction. Okay, and there's brisk constriction, and at the same time I'm checking for a consensual response by the right eye. And there is brisk response in the right eye. Now we're going to be looking for a direct response in the right eye, and there's brisk constriction, and now we're going to be looking for a consensual response in the left eye. And there is brisk constriction. So pupils are 3 millimeters. They are round and reactive to light, both direct and consensual. We're going to be checking for accommodation. So first I'm going to have you focus on something on the back wall. Now look at my finger. Okay. Eyes come in and converge, pupils constrict. That means that there is accommodation. So pupils are equal, round, and reactive to light with accommodation intact. Now we're going to be testing the patient's extraocular movements using the 6 cardinal positions of gaze. So I'm going to have you follow my finger using only your eyes. Patient's extraocular movements are smooth and full, no signs of eye muscle paralysis or nystagmus. At the same time, I'm also checking for any other eye muscle problems such as strabismus, and in this case, there are none. I'll be assessing the patient's corneal light reflex. So I'm going to have you focus on something on the back wall, and I'm going to shine a light into your eyes, and I'm just trying to make sure that the light appears symmetric in both eyes, which they do. So the patient has symmetric corneal light reflex. We're going to be performing the cover and uncover test, and this checks for any eye muscle problems or misalignment. So I'm going to have you focus on something on the back wall, and I'm going to cover and uncover each eye. Okay, eyes stay fixed. I see no movement in either eye to pick up fixation as I cover and uncover. Cranial nerves 3, 4, and 6 are intact. Cranial nerve 5 is the trigeminal nerve, and it has mixed function, meaning it has both motor and sensory function. The motor aspect of it mediates the muscles of mastication, or the temporal and masseter muscles. So to check this, I'm going to have you grind your teeth and move your jaw from side to side. My patient has a strong muscular response in the muscles of mastication. There don't appear to be any limitations in range of motion. So the motor aspect of this nerve is intact. The sensory aspect of this nerve mediates sensation along the 3 tracts of the trigeminal nerve, which are the forehead, cheeks, and chin. So I'm going to have you differentiate between sharp and dull. So first this is sharp, and this is dull. Okay, so please close your eyes and tell me what you think this is.
Sharp. Sharp. Dull. 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 Sharp. Sharp. Sharp.
Okay. Sensation is intact bilaterally on the 3 distributions of the trigeminal nerve. Cranial nerve 5 is intact. Cranial nerve 7 is facial, and it is a mixed nerve, so it has both motor and sensory function. The sensory aspect of the nerve mediates taste along the anterior 2/3 of the tongue, but for the purposes of this video, we will not be testing it. And then the motor function mediates muscles of the face. So I'm going to have you smile real big, grit your teeth, raise your eyebrows, puff out your cheeks. Okay. Facial movements are symmetric and intact bilaterally. Cranial nerve 7 is intact. Cranial nerve 8 is the acoustic nerve, and it is a sensory nerve that mediates hearing. To test this, we're first going to be using the whisper test. So I'm going to be whispering 3 words into each of your ears while the other one is occluded, and I just want you to repeat the words back to me. Okay, so first occlude your left ear.
Cat. January. Flower.
Okay. And occlude your right ear.
Pink. Tulip. Gym.
Okay. Hearing is intact to whispered word bilaterally. Now we're going to be conducting the Weber test using this tuning fork. I'm going to strike it and place it on your head, and you're going to tell me if you hear it better in one ear or if it sounds equal.
Equal.
Okay. So there is no lateralization of sound. For this test, if the sound lateralizes to the affected ear, then it is an indication of conductive hearing loss. And if it lateralizes to the non-affected ear, then it could be a sign of sensory neural hearing loss. Now we'll be doing the Renee test. And to do this, I'll be using the tuning fork again. I'm going to strike it and place it on your mastoid process behind your ear. You're going to tell me when you stop hearing the sound, and immediately after you stop hearing the sound, I'm going to move the tuning fork to be in front of your ear, and then you're going to tell me when you stop hearing that sound. Okay, ready?
Yeah. Okay. Okay.
Okay, so he heard the sound twice as long through air conduction as opposed to bone conduction. And then we're going to be doing it again with his left ear. Ready?
Yep. Okay. Okay.
Okay, and again, he heard the sound twice as long through air conduction as opposed to bone conduction. This is a normal response when sound is heard in a 2-to-1 ratio, air conduction to bone conduction. This can also be seen in sensory neural hearing loss. If the patient heard the sound in a 2-to-1 ratio, bone conduction to air conduction, then this would be an indication of conductive hearing loss. Cranial nerve 9 is glossopharyngeal and cranial nerve 10 is vagus. These are both mixed nerves. The sensory aspect of these nerves mediate taste in the posterior 1/3 of the tongue. They also mediate sensation in the posterior 1/3 of the tongue and in the throat. But for the purposes of this video, we won't be testing that. The motor aspect of these nerves mediates phonation and swallowing. So I'm going to observe your uvula first. So if I could have you open your mouth nice and wide, and okay, and stick out your tongue a little bit, okay, and say ah. Okay. The uvula rises and falls symmetrically at midline, no deviation. Now I'm going to assess your gag reflex. So if I could have you open your mouth again, stick out your tongue, and say ah. Okay. And the patient's gag reflex is intact. Now if I could just have you swallow. Okay, and his swallowing is intact. So the motor aspect of these nerves are intact. Cranial nerve 11 is the spinal accessory nerve, and it is a motor nerve. It mediates the trapezius and sternocleidomastoid muscles of the neck. So I'm going to have you shrug your shoulders, and I'm going to try to push them down and just try to resist. Okay? And then I'm going to put my hand here, and I'm going to push and try to push back, and then push back. Okay. So the patient can push against full resistance. Cranial nerve 11 is intact. Cranial nerve 12 is the hypoglossal nerve, and it is a motor nerve. It mediates tongue movement. So first I'm going to have you stick out your tongue. Okay. And tongue protrudes midline, and no deviation or tremor is seen. And now I'm going to place my finger on one cheek, and I'm going to try to push against it. And then another one. Okay. He has strong movements with his tongue. Cranial nerve 12 is intact. Moving on to the head and neck. First, I'll be assessing your face for any asymmetry. And your skull, scalp, and hair. I'm inspecting for any asymmetry as well. And there is no asymmetry noted. Now, I'm going to be palpating your frontal and maxillary sinuses, and just let me know if there's any tenderness in here. Anything?
No.
And here. Anything?
No.
So no tenderness upon palpation of the frontal and maxillary sinuses. And now I'm going to be assessing your temporomandibular joint. So if I could have you open your mouth, close your mouth, move side to side, and then protract like this, and retract. Does it hurt anywhere during
No.
those movements? Okay. So no tenderness upon palpation of the TMJ, no popping or clicking. Moving on to the ears, the auricles appear symmetric. They are both aligned with the outer canthus of the eyes bilaterally. And is there any tenderness?
No.
Okay. And there's no tenderness here, but if there were tenderness on the mastoid processes, it could indicate mastoiditis. Abnormal findings for the auricles or pinout would be anotia or microtia or any abnormal size, shape, rotation, or positioning. And now I'm going to be performing a tug test. So, anything?
No.
Okay. So if he were to have a painful tug test, then that would be a sign of potential acute otitis externa. Now I'll be performing an otoscopic exam, first on the left ear, and I'm going to return for the camera. There is no swelling, redness, or abnormal discharge seen in the external canal. Abnormal discharge would be clear discharge or bloody discharge. I do see a slight amount of cerumen. The cone of light is at the 7 o'clock position. The tympanic membrane is pearly gray. It's not bulging or amber or yellow, as might be seen in otitis media. And I'm able to identify the hammer and short process of the malleus. And moving on to the right ear. No abnormal discharge, no swelling or redness of the external canal. There's a slight amount of cerumen. The cone of light reflects at the 5 o'clock position. The tympanic membrane is pearly gray, not swollen or bulging or amber in color, as might be seen in otitis media. And I'm able to identify the hammer and short process of the malleus. For the nose, I'll be inspecting your mucosa and turbinates. I'll only be able to view the middle and inferior aspects. The superior is not visible. Okay, so I'm going to have you go like this. Okay. Nasal mucosa is pink. On the left and as well as on the right. Hairs are evenly distributed. Septum is midline, no deviation. There does not appear to be any obstruction. Nares appear patent. And just to confirm that, I'm going to obstruct one nostril again, breathe in and out, and opposite, and breathe in and out. Nares are patent bilaterally. Now I'll be assessing my patient's throat and mouth. Okay, so I can have you please open your mouth. And the tongue appears pink and moist. If I can stick it out. And it protrudes midline. Please open up a little bit wider. Buccal mucosa, pink and moist, no lesions. The roof of the mouth is pink and moist. There are no lesions. If I could have you lift up your tongue. The floor of the mouth is pink and moist. No lesions. The teeth are intact. No dental caries. And I'm just going to use one of these. The gums appear intact and well secured to the teeth. They are pink and moist. No gingivitis or gingival hyperplasia. Sorry. And stick out your mouth again. Sorry. The tonsils are in a 1+ or +1 position. 1+ means that they are visible. 2+ means that they are halfway in between the tonsillar pillars and the uvula. 3+ means that they are touching the uvula, and 4+ means that they are touching each other. The oropharynx is pink and moist. There are no lesions. The uvula is pink and moist. It is midline. Just say "ah" for me. And it rises and falls midline. Other abnormalities that might be seen in the throat and mouth are issues with the hard or soft palate, such as seen in cleft lip or palate, dental caries, gingivitis, as I've said, candidiasis, tonsillitis, and pharyngitis. The Mallampati airway classification is used to predict a patient who might have a difficult airway or intubation, or someone who might have obstructive sleep apnea. Class 1, in Class 1, you're able to have complete visualization of the soft palate. Class 2 has complete visualization of the uvula. Class 3 has visualization only of the base of the uvula. And Class 4, you're not able to visualize the soft palate at all. So for my patient, if I could have you open your mouth. He is a Class 1. Now I'm going to be assessing the neck for any asymmetry, masses, tracheal deviation, or goiter. So looking at your neck, there does not appear to be any masses or asymmetry. My patient's neck is symmetrical. To check for tracheal deviation, I'm going to start at the sternal notch and move superiorly. And the trachea is midline. And now I'm going to be looking for the thyroid isthmus. And if I could have you swallow, look down, and then turn to the right, turn to the left. Okay, and then just look straight. I'm going to displace it to the right and palpate, to the left, and then displace it to the right and palpate. There does not appear to be any thyroid enlargement or nodules. Now I'll be palpating the lymph nodes of the head and neck. A normal lymph node would be less than 1 centimeter, soft and mobile, and an abnormal lymph node would be greater than 2 centimeters, hard and fixed. So first, submental, submandibular, tonsillar, preauricular, postauricular, occipital, superficial cervical, deep cervical chain, supraclavicular, and infraclavicular. And none of the lymph nodes are palpable, and this is a normal finding. Now I'll be assessing the thorax, beginning with the posterior chest. The posterior chest appears symmetrical, elliptical in shape. The transverse diameter is greater than the AP diameter. There does not appear to be any masses, nevi, scars, or lesions. There is no structural abnormalities such as kyphosis, lordosis, or scoliosis. And now I'll be palpating for tenderness, so let me know if it is tender anywhere. Anywhere?
No.
And there is no tenderness. Now we'll be assessing for chest expansion at the 10th rib. So if I could have you take a deep breath in. Okay. And chest expansion is symmetrical. Now I'll be palpating for tactile fremitus. So each time I press my hands on your back, say 99.
99. 99. 99. 99.
So tactile firmness should be increased most in the intrascapular region, and it would also be increased over areas of consolidation. Now we'll be percussing the posterior chest. Resonance is percussed in all areas of the lungs. Dullness would indicate consolidation. Hyperresonance would indicate increased air-filled spaces, such as in emphysema and COPD. And a flat sound would be percussed over bone. Now I'll be percussing for costovertebral angle tenderness, or CVA tenderness. Does that hurt?
No.
Now I'll be auscultating the posterior chest. Each time my stethoscope touches your back, I want you to inhale and exhale. Lung sounds are clear to auscultation. Normal breath sounds include bronchial sounds, which could be auscultated over the trachea, bronchovesicular sounds, which would be auscultated in the midscapular area, and there's also vesicular lung sounds, which would be auscultated in the lung periphery. Adventitious sounds include crackles, which sound like short, crackling, popping sounds, wheezing, which are high-pitched squeaks, rhonchi, which sound like snoring, and then there's rales, which is like a fine, high-pitched crackling. Now I'll be auscultating for bronchophony. So each time my stethoscope touches your back, I want you to say 99.
99. 99. 99. 99. 99. 99. 99.
So the sound is muffled, which is a normal finding. If I could hear it loud and clear, then that would indicate a possible area of consolidation. I'll begin the assessment of my patient's anterior chest by inspecting, and upon inspection, the anterior chest is symmetrical, elliptical in shape, as indicated by the transverse diameter being greater than the AP diameter. No barrel chest is noted. No masses, lesions, scars, nevi, no retraction or bulging of the in the intercostal spaces, no structural abnormalities such as pectus excavatum or pectus carinatum. And I'll be assessing the respiratory rate and rhythm. And the rate is 16, and it is a normal rate and rhythm. I'll be palpating the anterior chest for any tenderness or masses. So let me know if it feels tender anywhere.
No.
No tenderness or masses noted. And I will be describing how I would percuss the anterior chest symmetrically. Normal sound of percussion would be resonance over healthy lung fields. Dullness would be percussed over the heart, but this would not be percussed on the posterior thorax. And dullness would also be percussed over areas of lung consolidation. Now I'll be auscultating the anterior chest. Each time my stethoscope touches your chest, I want you to inhale and exhale. Lung sounds are clear to auscultation. Bronchial sounds are not heard on the posterior exam, but they are heard on the anterior exam, and they're located over the bronchial main tree and the tracheal area. Bronchovesicular sounds are heard in the middle of the anterior chest, between the first and second intercostal spaces, and then vesicular sounds are heard in the lung periphery. An example of an adventitious lung sound is wheezing, which is like a high-pitched squeak. Moving on to the cardiovascular and peripheral vascular systems. I'll first begin by describing the 6 precordial areas. Aortic is at the second intercostal space, right sternal border. This is where you will hear S2 the best. Pulmonic is at the second intercostal space, left sternal border. This is where you will hear a split S2 the best. It is also where sound varies the most with sound. Herb's point is at the third intercostal space, left sternal border. Tricuspid is at the fourth intercostal space, left sternal border. This is where you will hear a split S1 the best. Mitral is at the fifth intercostal space, left midclavicular line. This is where you will hear S1 the best. It is also where, if in the left lateral decubitus position, you will hear S3, S4, and mitral valve prolapse the best. The epigastric area is just below the xiphoid process, slightly to the left. It is where you will see or feel pulsations if there is heart hypertrophy. As far as murmurs, mitral regurgitation murmur and aortic stenosis can best be heard during systole. I'll be describing the squat test as well as the Valsalva maneuver. For the squat test, you would listen at the apex or mitral area with the patient standing, and as they squat, if the click diminishes or goes away, then it is probable for mitral valve prolapse. If the click is accentuated, then it is likely an opening snap from aortic stenosis. For the Valsalva maneuver, you would listen over the mitral area or the left lateral sternal border with the examiner's hand over the patient's abdomen. You would ask the patient to bear down. If the sound becomes louder, then it is probable for mitral valve prolapse, and if the sound becomes quieter or diminishes, then it is probable for aortic stenosis. Now I'll be inspecting the 5 precordial sites for any pulsations, heaves, or lifts. And there are none. And now I'll be palpating for any thrills or pulsations. And there are no thrills or pulsations. I'll be palpating for the apical impulse, which is also the point of maximal impulse. It should be at the 5th intercostal space, left midclavicular line. I am palpating for a pulsation that should be about 2.5 centimeters wide, brisk, about 2/3 of systole. If it is laterally displaced, it could be a sign of heart enlargement. If the area is larger or more diffuse, then that could also be a sign of an enlarged heart. If it is sustained, it could be a sign of hypertrophy. And if it is more than brisk or hyperkinetic, it could be because the patient is young, they have anemia, or they might have just exercised. Now I'll be assessing the arteries for the pulses bilaterally and comparing them. Pulses can be graded from 0 to +3. 0 is absent, +1 is weak or thready, +2 is normal or brisk, and +3 is bounding. So first I'll begin by assessing the radial pulses, and I'll also be determining my patient's peripheral pulse rate from here. And from that, I determined that his rate is 68, and his radial pulses are +2 bilaterally. Next, I would palpate for the femoral pulses, but for the purposes of this video, I will just be describing it. So this can be found halfway in between the superior iliac spine and the pubic symphysis within the groin region bilaterally. And then I will be palpating for the popliteal pulses. And these are +2 bilaterally. And then the posterior tibialis pulses. And these are +2 bilaterally. And then the dorsalis pedis pulses. Are +2 bilaterally. I will be assessing the lower extremities for edema, and there are 3 types. The first is pitting edema. Pitting edema is a type of swelling that, when pressed in with the thumb, can cause a pit or depression, and this can be graded on a scale from 1+ to 4+. 1+ is pitting of 2 millimeters or less and rebounds instantaneously. 2+ is pitting of 2 millimeters to 4 millimeters, and this could take up to 15 seconds to rebound. 3+ is pitting of 4 millimeters to 6 millimeters, and this could take up to 30 seconds to rebound. And then 4+ is pitting of 6 millimeters to 8 millimeters, and this could take greater than 30 seconds to rebound. And then there's also dependent edema, which is a type of swelling in the lower extremities when a patient or an individual has been sitting or standing for too long. And then there is anasarca, which is generalized swelling usually caused by kidney or liver failure or damage. Looking at my patient's lower extremities, there is no sign of edema. Now I'm going to assess my patient's skin temperature on the upper and lower extremities. On the upper and lower extremities, his skin temperature is warm. Cold or very hot would be abnormal. Now I'm checking for the capillary refill in his upper and lower extremities. And it is less than 2 seconds. Normal would be less than 2 to 3 seconds, and greater than 3 seconds would be considered prolonged capillary refill. I'll be assessing my patient's skin turgor by slightly pinching just below the collarbone. And it returns to normal within 2 seconds. If it tents, then it could be a sign of dehydration. Moving on to the gastrointestinal system, I'll begin by inspecting my patient's abdomen. There is a round contour, no masses, scars, striae, nevi, lesions, masses or dilated veins. If there is marked lateral pulsation, then that could be indicative of a AAA, and that should not be palpated. I'll be auscultating the 4 quadrants of the abdomen to listen for bowel sounds. Normal active is 5 to 30 clicks or gurgles per minute. Hypoactive is 3 to 5 bowel sounds per minute, and hyperactive is more than 30 bowel sounds per minute. Borborygmy is the characteristic rumbling of that the stomach and intestines make when food or gas is being passed through. And my patient's bowel sounds are normal active. I would also auscultate for friction rub, which is a grating sound that can vary with respirations. I would auscultate over the liver and spleen, as it could be hepatic or splenic. It indicates inflammation on the peritoneal surface of the organ caused by a liver tumor, chlamydia, gonorrhea, recent liver biopsy, or splenic infarct. When heard with a systolic bruit over the liver, one should consider hepatic carcinoma. I would also auscultate for a venous hum, which is a soft systolic and diastolic hum. It is rare but can be heard over the liver, epigastric, or umbilical regions. It indicates increased collateral circulation, such as in hepatic cirrhosis. I'll be percussing all 4 quadrants of my patient's abdomen. I percussed a tympanic sound, generalized over the abdomen, which is normal. However, dullness can be percussed over solid organs such as the liver and spleen. For organomegaly, or specifically hepatomegaly, one would percuss dullness that should be about 6 to 12 centimeters along the right midclavicular line, and about 4 to 8 centimeters along the midsternal line. Greater than those values would indicate hepatomegaly. Based on my percussion, my patient does not have hepatomegaly. Now I will be palpating the 4 quadrants of my patient's abdomen, beginning in the right lower quadrant and moving up the cooling path. First, I will start with light palpation. And did that feel tender at all?
No.
So no tenderness or mass is noted, and now I will be using deep palpation. And did that feel tender at all? No tenderness or mass is noted upon deep palpation. Also, for organomegaly, I did not palpate any hepatomegaly or splenomegaly. I will be assessing the superficial abdominal reflexes. Beginning with the upper abdominal reflexes, these affect spinal segment T8, 9, and 10. And now the lower abdominal reflexes. These affect spinal segment T10, 11, and 12. Now I'll be performing special tests to assess for appendicitis, first beginning with rebound tenderness. Does it hurt when I take my hand away?
No.
Pain there would indicate appendicitis. Now the psoas sign. Does it hurt on your right lower abdomen?
No.
And pain there while lifting the leg would indicate appendicitis. And now the obturator sign. Did that hurt?
No.
And pain would indicate appendicitis. And now Rovsing sign. Does it hurt on your right lower side?
No.
And pain there would indicate appendicitis. And now I will be performing Murphy's sign for cholecystitis. So I want you to take some breaths, deep breaths. Does it hurt?
No.
Sudden inspiratory arrest would indicate pain there, which is a sign of cholecystitis. For the musculoskeletal system, I will be conducting range of motion exercises on myself. This is finger flexion, extension, abduction, adduction, wrist flexion, wrist extension, ulnar deviation, radial deviation, elbow flexion, elbow extension, supination, pronation. This is shoulder flexion, extension, circumduction, internal rotation, external rotation. This is neck flexion, extension, rotation to the right, rotation to the left, right lateral bending, left lateral bending. This is spinal flexion, extension, rotation to the right, rotation to the left, right lateral bending, left lateral bending. This is hip flexion, extension, abduction, and bringing together is adduction. There's also internal rotation and external rotation. And then for the knees, this is knee flexion, and bringing it straight is knee extension. This is ankle plantar flexion, dorsiflexion, inversion, and eversion. This is toe flexion, and this is toe extension. Muscle movement can be graded on a scale from 0 to 5. 0 is no muscle movement. 1 is trace or flicker movement that can be seen or felt. 2 is active movement with gravity eliminated. 3 is active movement against gravity but not against resistance. 4 is active movement against gravity and light resistance. And 5 is active movement against gravity and full resistance. I will be assessing for knee joint stability by first applying varus LCL stress on his knee. And now valgus MCL stress on his knee. I'll be performing the anterior ACL drawer test and the posterior PCL drawer test. I'm going to perform the McMurray's test to assess for meniscus injury. I will be assessing for lower back pain by first performing the straight leg raise. So tell me when you feel any pain. Anything?
No.
Anything?
No.
Now I will be palpating the paravertebral muscles and let me know if you feel any tenderness or spasms. Anything?
No.
Anything?
No.
Okay, no tenderness or spasms noted. Now I will be palpating for point tenderness over the spinous processes. Anything?
No.
And there is no point tenderness over the spinous processes. I would also assess for limitations in range of motion, however, that was already assessed in the range of motion portion of this video. We will be assessing for carpal tunnel syndrome, first using the Tinel sign. So let me know if you feel any numbness or tingling when I tap.
No.
Okay, and then the Phelan sign, so go like this. Have your wrist touch, okay. And do you feel any numbness, tingling, or pain?
No.
Okay, so both of these tests are negative. The rotator cuff muscles consist of the supraspinatus, infraspinatus, teres minor, and then anteriorly It is the subscapularis. I will be assessing his shoulder muscle strength against resistance. So first I'm going to have you go into shoulder flexion and try to resist. Okay, and then shoulder extension. Okay, try to resist. Okay, and shoulder abduction and shoulder adduction. So try to bring your arm in and then try to resist. Okay, and then we're going to have you do internal rotation. So try to resist, and then external rotation. Try to resist. Okay, and then just circumduction is just spinning your shoulder around. Okay. Now we will be performing the Apley scratch test to assess shoulder range of motion. So, okay, Raymond, if I could have you perform this test by trying to scratch, or trying to have your two hands touch each other on your back. Okay, and then opposite way. Okay. Okay, we will be performing the drop arm test. So I'm going to bring your arm out. Okay, and then just hold it and bring it slowly down. Okay. If there was a tear in his rotator cuff, then he would not be able to control the downward movement of his arm or the movement of his shoulder. Now we are performing a scoliosis test by assessing the heights of the shoulders. And they appear even, and then the iliac crests are at the same level. And then the scapulae, there's no winging or any kind of protrusion. And now we're going to have you bend over, and I'm going to look for any abnormal curvature. So, sorry, can I have you come back this way? Okay, and go ahead. And the spine appears straight. There's no lateral curvature. You can come back up, as would be seen in scoliosis. We are going to test for coordination by first assessing the patient's gait. So if I could have you just walk forward. And his gait is coordinated. We'll test coordination by assessing rapid alternating movements, such as touching each of your fingers to your thumb and then just alternating back. And there is coordination of rapid alternating movements. Now we will assess coordination by using point-to-point tests, such as the finger to nose. So if I could have you turn my way. I'm going to stick out my finger, and you're going to touch your index to my index finger and then touch it back to your nose. And then every time I move my finger, you're going to touch it and then go back to your nose. Okay?
Okay.
Okay. Go back to me. Okay. And there is coordination with the finger to nose assessment. We will assess using the heel to shin test for coordination. So if I could have you touch your heel to your knee and then slide it down your shin, and then with the other leg, and there is coordination. We'll perform the Romberg test by having your feet together. Okay, and your eyes are open, and now we will do the same thing, feet together with your eyes closed. Any abnormal swaying or loss of balance would be a positive Romberg test, and in this case, he did not lose balance, he did not have any swaying, so that is a negative test. Now we will be performing the pronator drift test. If I could just have you extend your arms out with your eyes closed. Okay, and he is able to keep his arms extended without any excessive swaying or loss of coordination in his arms. Now we will be assessing sensation in the upper and lower extremities. First, I'm going to have you differentiate between sharp and dull. This is sharp, and this is dull. Okay, so close your eyes. Tell me if you think it is sharp or dull.
Sharp, sharp, dull, dull, dull. Sharp, sharp, dull, 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 dull.
Okay, patient is able to distinguish between sharp and dull pain stimuli. And now we will be doing light touch. So just close your eyes, and then when you feel like you've been touched, just say now.
Now. Now. Now. Now. Now. Now. Now. Now. Now. Now.
Okay. And he is able to feel light touch. Now we will be assessing discriminative sensation. First, assessing stereognosis. So if you could just please close your eyes and open your hands, palms up. I'm going to be placing 2 different items in your hands, and you're going to tell me what you think each item is. So the first one.
Key.
Okay, and then this one.
Battery.
Okay. Stereognosis is intact. And now we're going to be assessing for graphesthesia. I'm going to be drawing a number or a letter in your hands, and you're going to tell me what you think I drew.
B. 7.
Correct. Graphesthesia is intact. Deep tendon reflexes can be graded on a scale from 0 to 4 plus. 0 is no response, 1 plus is diminished or low normal, 2 plus is normal or average, 3 plus is brisker than average, and 4 plus is very brisk and hyperactive with clonus. Now we will be assessing the deep tendon reflexes, beginning with the brachioradialis or supinator reflex, which affects C5 and C6. So if I could have you relax your forearm against your leg, and then we'll do the other one. And there you could see his brachioradialis deep tendon reflex. We'll be looking at the biceps deep tendon reflex, which affects C5 and C6. So just relax. The triceps deep tendon reflex affects C6 and C7. So I'm going to have you just relax your arm. Okay, and then the other side. Okay. The knee deep tendon reflex affects L2, 3, and 4. The ankle deep tendon reflex affects S1. Now we will be assessing meningeal signs such as the Brzezinski sign. So I'm going to bring your neck forward. And that is a negative sign. A positive sign would be if during passive neck flexion, his knees would also bend and flex. Now we'll be assessing Kernig's sign. So I'm going to flex your knee. Does that have cause any pain at all?
No.
Okay, so that is a negative Kernig's sign. If he was unable to extend or if it was painful, then that would be a positive sign and indicative of meningitis. Thank you, Raymond. My assessment is complete.
Thank you.